everyone, and welcome to today's Public Health Ontario Rounds presentation, Online Public Health Nurse Delivered Group-Based CBT for Postpartum Depression, Results of a Randomized Controlled Trial. My name is Sarah Carsley, and I'm the Applied Public Health Science Specialist in Healthy Growth and Development at Public Health Ontario, and I have the pleasure of moderating today's session. As we begin today's rounds, I would like to acknowledge that I am here in Toronto on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. I also acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaties, signed with multiple Mississaugas and Chippewa bands. I'll now mention a few housekeeping items. The chatbot has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have questions during the session. A discussion and question period will follow the presentation. If at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. I would like to state that as the moderator of this session, I have no conflicts of interest to declare. It is now my pleasure to introduce the speakers for today's presentation: Ryan Van Lieshout, Amanda Hicks, and Christina Bradley. Dr. Van Lieshout is a psychiatrist and clinical epidemiologist at McMaster University who is interested in developing and testing interventions aimed at improving access to care for birthing parents struggling with postpartum depression. This work also examines the impact of these interventions on infant neurodevelopment and subsequent psychiatric risk. Amanda Hicks is a public health nurse and has been supporting maternal child health as a program manager in the Family Health Division at Niagara Region Public Health since 2008. And Christina Bradley is a public health nurse and lactation consultant at Niagara Region Public Health, focusing on family support through outreach services. Thank you all for being here. I will now pass it over to Amanda.
Thanks, Sarah. Hi, everybody. It's nice to be back. Thank you so much for having us back again to share some new findings and additional context around this topic. Our objectives today are, through the session, we're hoping to briefly describe the prevalence and impact of postpartum depression on birthing parents and families. Our primary objective really is to help you understand the effects of online public health nurse delivered group cognitive behavioral therapy for postpartum depression on maternal depression, anxiety, the mother-infant relationship, and infant temperament. We also hope that we'll be able to explore how public health nurse delivered group CBT for postpartum depression could be implemented in public health units across Ontario by sharing really how it's been implemented in the Niagara region. We're hoping to achieve these objectives by providing context and findings within the areas that you see here. So I'll start just with a few reminders really for this group about postpartum depression. We know that it affects at least 1 in 5 mothers or birthing parents. And the impact, if left untreated, really increases the risk of later depressive episodes, relationship problems, and cognitive, emotional, behavioral problems in offspring. It is an expensive diagnosis, so a single case can cost as much as $100,000 across the lifespan. And only 10 to 15% of individuals with postpartum depression are able to access evidence-based care. I'm going to pass things over to Ryan to take you through the next set of slides.
Thanks very much, Amanda. As this audience knows, the COVID-19 pandemic has had a big impact on everyone, but we think that it may have had a particularly deleterious impact on individuals who had infants. We believe that rates of postpartum depression and postpartum anxiety increased during the pandemic, and we think that this is for a number of reasons. Obviously, a lot of individuals were concerned about contracting COVID-19 and or passing it on to their children. But these individuals were also faced with significant social isolation. We know that there were lockdowns and other things, but given the fears about infants and physical health and so forth, and how hard it can be to get support in the postpartum period anyways, these individuals were particularly isolated. Of course, they not only had to raise an infant, if they had older children, they had them at home as well. Sometimes they had to play the role of teacher during homeschooling, and they also often were supporting partners too. During this time, although a lot of agencies and services were able to pivot and move online, there was a general decrease in ability to access mental health care. And because of so many different opinions and feelings and concerns around COVID-19, a lot of mothers and birthing parents also were faced with less support from their family and friends. So these COVID barriers to care were in addition to the barriers to care that existed before the pandemic. We know that mothers and birthing parents struggling with their mental health around the delivery of an infant faced long wait lists for OHIP insured services, high costs for private therapy, and limited availability even before the pandemic. And now a lot of private clinics have long wait lists as well. Other barriers to getting evidence-based care include the general lack of availability of psychotherapies, and these are treatments that a lot of mothers and birthing parents really prefer after delivery, particularly if lactation is a factor. And a lot of people were concerned about having to take antidepressants, the most widely available treatments. So in order to increase access, my research group and Niagara Region Public Health has been interested in trying to figure out ways to creatively enable people to get access to the treatments that they want, usually psychotherapies. And so we've been using task shifting. So task shifting is, of course, the process of delegation whereby services are moved from specialized and more costly people like me, a psychiatrist, to experts with less formal training and at lower cost. And public health nurses, I think, are just a fantastic group to task shift some of the care, or task share the care of postpartum depression with. They're often a first point of contact for a lot of individuals who might be struggling with their mental health after the delivery of an infant. And we know from research that registered nurses are the preferred non-specialist provider of psychotherapy for postpartum depression. So people prefer you guys as well. When public health nurses are polled, they feel that their role should involve not just screening and detection, but also participating in treatment and management. And even though formally not necessarily always assigned to treatment, a lot of what public health nurses do with clients is management related. And of course, registered nurses are authorized by the Regulated Health Professionals Act to provide both psychotherapy and the controlled act of psychotherapy. So that's a fun designation, but we'll leave that for today. So nurses have been delivering talking therapy, psychotherapy for postpartum depression for some time. And there are lots of studies that have looked at nurses and nurses with lots of training delivering psychotherapy, talking therapies to people with postpartum depression. Most of these studies involve nurses that had a lot of prior training in mental health, so specialty mental health training. And most of the treatments that they administered were actually one-on-one treatments, so individual treatments. While these can be very effective, they're not particularly cost effective, and some might think that individual treatment by public health nurses might run a bit counter to public health sort of. So we shared with you guys the results of our public health nurse delivered group cognitive behavioral therapy for postpartum depression randomized control trial that was delivered in person. This was prior to the pandemic, where we trained a group of public health nurses from Niagara region to deliver this group. And the nurses that participated as facilitators of the group didn't have extensive previous psychiatric training, and they didn't have a lot of experience delivering psychotherapy groups, particularly. So in that trial, we randomized 141 individuals, 141, they all identified as mothers, but mothers and birthing parents, to receive usual care plus the 9-week CBT intervention, or they got usual care alone. And we looked at how they did at baseline, or how they were doing at baseline, immediately after the 9-week group, and then 6 months later. And what we found was that it was effective at improving postpartum depression and anxiety, and improving the mother-infant relationship. And we were really happy to find that after just 9 weeks, 9 weekly sessions, that the improvements that we saw at immediately after treatment persisted for 6 months after the treatment. So of course, around March 18th, 2020, the COVID-19 pandemic hit. And about a week after that, after I think we all got our bearings, I had a phone call with Ann Biscaro, Director of Family Health at Niagara Region Public Health, just to catch up. We're going to talk about how the previous study had gone. And we were both talking about what we were seeing firsthand. Ann, of course, as a manager and managing her division, and myself spending lots of time on Zoom and on the telephone with patients in my clinic. And we were seeing very early on that new moms were a very vulnerable group, and that all of these risk factors, social isolation, lack of access to services and so forth, were going to be a real problem. And even then we didn't know how long it was going to last. So we both came to the conclusion that we wanted to do something, and we thought that there was a clinical imperative that we could meet, and also we felt like there were some important questions to be answered, particularly could the nurses deliver effective group CBT for postpartum depression online? How would that affect access? How would the nurses do, and so forth? And so we agreed to, so she was kind enough to provide some of the nurse time in kind, and I had some money left over from a career award, so we agreed to conduct another randomized control trial. The objective of this trial was to determine if public health nurses could deliver effective online group CBT for postpartum depression, and we wanted to see its impact on postpartum depression and anxiety, social support, the mother-infant relationship, and infant temperament as well. And doing another trial in a slightly different way was also designed to help us determine if this could be translated and scaled. So we were trying to figure out, could this be delivered online, and if it could we then work with Niagara Region and potentially other public health nurses units, excuse me, to use it in practice. So what we did is as I said earlier, we randomized mothers and birthing parents to either receive treatment plus the CBT group plus treatment as usual care versus usual care alone. Individuals who were eligible for the trial were mothers and birthing parents who were over 18 years of age. They had to have babies less than 12 months of age at enrollment, and an Edinburgh postnatal depression scale of 10 or more. We chose this cutoff because we wanted to be as inclusive as possible, and it captures the fact that postpartum depression probably exists on a continuum rather than there being some actual cutoff where it makes a huge difference. And we looked at the things we outlined in the previous slide. You see we collected data at baseline, immediately after treatment, and then 6 months later again. So we had a lot of interest. 159 individuals were randomized, 80 into the treatment group and 79 into the control group. At baseline, the participants were about 31 years of age. Most were married or common law. 20% identified that they were born outside of Canada, and they enrolled around when their infants were about 6 months of age. Half of the individuals were primates. And the mean baseline EPDS score was about 15, so in the moderate range. So what did we find? So in the following slides, the treatment group is the solid line and the control group is the hashed line. So what we saw when immediately post-treatment, that's T2, is we found a rapid and robust decrease in depressive symptoms in the treatment group. And the difference between the treatment and control group at time 2, immediately after treatment, was nearly 5 points. To provide some context, a change of 4 points or more is thought to be a clinically significant difference. So the changes were not only statistically significant, but also clinically meaningful. And you see by the solid line that the gains were persisted out to 6 months post-treatment. Actually, they improved a little bit. So to add additional clinical relevance to the findings, we looked at the proportion of individuals in the treatment and the control groups that experienced a 4-point or more decrease. And what we found was that individuals in the treatment group were 3 times more likely to experience this clinically significant change compared to the individuals in the control condition. If we want to take clinical significance one step further, we also did structured clinical interviews using the Mini International Neuropsychiatric interview with all participants. We found that about 60% of individuals in the experimental and control group had full-blown major depressive disorder at the start of the trial. But what we found after the treatment group got the group delivered by the nurses was that the prevalence of major depressive disorder decreased to 16% from 58%. And so individuals that got the treatment were 5 times more likely to experience a remission of their major depression compared to those in the control group. As far as anxiety and worry goes, again, there was a statistically significant, significantly greater improvement in anxiety and worry in the treatment group relative to the control group. And you see that it also persisted out all the way to 6 months. We also found that when we used the Mini to assess something called generalized anxiety disorder, the most common anxiety disorder, we saw that individuals that got the treatment were 4 times more likely to experience a remission of their generalized anxiety disorder as well, relative to the control group. So in addition to depression, anxiety, and worry, we also examined the impact of the intervention on the mother-infant relationship. And what we found was that levels of rejection and pathological anger toward the infant was decreased with treatment, more in the treatment group than in the control group, and that these gains not only persisted but continued on up to 6 months after the treatment ended. So I commented on this as we went through the slides, but we just wanted to highlight that even though this was a 9-week treatment, so weekly for 9 weeks, we noticed that even after treatment ended, that people remained well. And this is such an important thing for participants, but also for the public health impact of the intervention. One thing we did see is that in terms of the infant temperament, that a difference emerged between the 2 groups at 6 months. It wasn't there right after treatment, but the infants in of the individuals in the treatment group had larger improvements in something that's called surgency or positive affectivity. So the babies were more happy, easily soothable, cuddly, and things like that. So we saw improvements in the infants. It just took a little bit longer to emerge than the changes with the mothers and birthing parents. We looked at some other outcomes. You would have picked that up from the description of the study at the beginning. So we also looked at social support, mother-infant bonding, and infant-focused anxiety. And what we saw was that social support increased numerically, but it was not statistically significantly greater in the treatment group. We're wondering if it's a scale issue, but it might simply not have improved social support. That's another possibility. And in terms of mother-infant bonding and infant-focused anxiety, both of these things improved more in the treatment group, but the differences were not statistically significant. So now I'd like to hand the floor back over to my colleague from Niagara Region Public Health, Amanda Hicks.
Thanks very much for sharing those findings, Ryan. And I'm very excited to share where we are now and where we're heading in Niagara. So following this further study into the online delivery of the intervention and evidence of impact on depressive and anxiety symptoms, along with alignment locally for us in Niagara in terms of our department's priorities, particularly related to mental health promotion, early child development, addressing adverse childhood experiences. Implementing the intervention into our core programming was really an easy sell, especially in the absence of other accessible evidence-based interventions for this population. In addition, we had really growing evidence coming from our outreach with our community, the Healthy Babies, Healthy Children screen risk factors, and the Ontario Parents Survey that mental health of the parent population and the postpartum population in particular was really a concern coming out of the pandemic. And we know that parental mental health is really at the crux of early child development and family well-being. So we carried on to implement the virtual or online delivery of the 9-week CBT intervention by public health nurses in Niagara, and launched our first post-study group September of 2021. Since that time, so between September and July, the end of July 2022, we have been able to facilitate 7 9-week groups. Within those groups, I think we ended up having 55 participants. We did have a bit of an attrition, so nearly 40% didn't complete all 9 sessions. So I will preface that that's something, that we're looking at from a CQI perspective. We do have a question on a post survey about reasons maybe for missing any of these sessions. So that's a piece that we're taking away. But of those clients, 33 of them who had attended 7 or more of the 9 weeks, we were able to have some feedback, so some survey data, and for 28 of them had pre and post Edinburgh postnatal depression scales completed. What's really exciting for us is that 92%, this is the first time we've been able to look at this data actually locally, preparing for the rounds. So we're really thrilled that 92% of those clients had a clinically significant decrease on their EPDS scores, so at least 4 points from pre to post. And the average decrease from pre to post on the EPDS was 8 points, which is really, I think, quite an impact for this population. I wanted to share as well some of the feedback that we've been receiving. So in addition to measuring pre and post EPDS scores, we have been collecting a post-intervention survey, and some of the feedback I'll share with you here. Welcome to read through. In addition to those you see here, we had a client describe an excellent program with wonderful facilitators. I was skeptical about the online format initially, but this program was wonderfully and effectively delivered. And recently we've been able to share testimony from one of our clients who participated in the intervention through some of our social media channels. So she was agreeable to share her story. And one of her comments was, if you're doubting to join the group, I can definitely recommend to give yourself that chance and try to join. It has been life-changing for me, and I promise it will for you too. Sometimes these are, the impacts that are not measurable, but can really resonate for other clients that might be thinking about trying an intervention and for our community. I'm going to pass things over to Christina, one of our experienced facilitators in the CBT intervention, to just talk about her experience delivering the 9-week intervention virtually.
Thanks, Amanda. So some of the strengths that kind of came out from this experience was it was a relatively fluid transition to the online format. We were able to adapt and pivot rather quickly and get that virtual format up and running. Any kind of board work or group activities, we were able to switch those to screen share activities to continue that level of interaction that happens during our groups. Because of redeployment, we had rather consistent facilitators that were trained in the delivery of the program. So having that consistency, I think, really added to the groups, as well as just increasing our skill set and our confidence in supporting individuals and families from postpartum depression. We were seeing that on an individual level, how we were working one-on-one with clients, and also within this group format. We noticed that, attendance during the restrictions, right, when we were in lockdown in that early pandemic, attendance and attrition was very high. People were able to attend, people made commitments to attend, And what was nice about the virtual format is that we had people attending if there was a personal illness. We had people attending while they were on vacation up at the cottage. One individual attended while on her honeymoon, even if there was childcare issues, right? Being in that virtual format, we found that clients did make it a priority to attend groups. Some of the challenges being in that virtual format, and being in Niagara, which is composed of 12 municipalities, we have a urban and rural mix, some internet accessibility and stability for some of our more rural clients sometimes did pose to be a challenge. And we kind of recognize that in terms of group cohesion and expression of empathy, not always, but sometimes was a little bit more challenging online, because clients, kind of similar to today, right? You would have yourself on mute while other people are sharing. Sometimes they wouldn't unmute themselves in order to, share their empathy, share their thoughts with other participants in the class. For these just kind of little impromptu moments, which would happen more naturally in an in-person group setting. We didn't say we couldn't use the chat feature. We didn't say, please use the chat feature. The chat feature, we just would let happen organically, and whether or not that turned out to be a group norm for the group. So sometimes that's a little bit of an extra challenge for the facilitators, because you then need to moderate the chat as well as, moderate the group and the activities at the same time. So that's just a little bit of an additional a role that the facilitators would have to take compared to in person. For confidentiality instructions, we found that we had to repeat those just a little bit more because people in their home setting, we really encourage that they found a private room. Children, obviously, and babies caring for their little infants were welcome, but we didn't want to see, other adults or child caregivers being in the background, so that confidentiality of the group was protected. So we had to do some reminders for that throughout the group. And then lastly, because of the COVID restrictions, part of the strategies that we really encourage is accessing supports and doing things like behavioral activation, in terms of doing things that you like to do, crossing things off your to-do list. And when COVID restrictions were in place, those strategies were sometimes really challenging for some of the clients to implement. But really great conversations did come out of that, and some really creative solutions as well. We had one mom for accessing supports. What she did was she put her laundry out on the front step, and her mother-in-law would come and pick it up and do the laundry and drop it off a couple times a week. And that's how she was able to access one of those more practical supports from her support system. So I'm just going to pass that back to Amanda now.
Thanks so much, Christina, for sharing about your experience and the experience of the facilitators and journey that we've had. I'm really excited to share what's next, where we're, sort of where we're heading, recognizing, the spectrum of severity of illness and symptomology in terms of postpartum depression, anxiety, and that there are some subpopulations that may have different needs. I'm really thrilled that we're able to be adaptive and responsive in Niagara. We have had, this has been a several years journey for us in terms of CBT interventions. And we're at a point now where we're able to continue to offer the 9-week group CBT intervention. And we're doing that both online and in person. We've just resumed some in-person groups this fall. We are also happy to be part of another research partnership with Ryan and his team, studying the public health nurse delivery of a 1-day, more psychoeducation-based workshop. We've also been able to facilitate an adapted program with a local agency to us called Strive Niagara, and one of the programs that they deliver is like a young parents alternative education program. And so we've been able to work with Ryan and then the staff at Strive to implement something we're calling building resilience, which is CBT skills with some additional considerations given the population in that program area. We're also, we've been very thoughtful about ensuring quality and fidelity as we have moved from research into practice, and have set up some supports for the facilitators, including, a community of practice to really share and address any practice-based or clinical issues. Reflective supervision support, so our nurses do have access to reflective supervision as needed, being able to access clinical consult and supervision as well as needed from Ryan and from the clinicians that work with him, and some theory to practice training for other program staff. So we've been fortunate to be part of testing and expansion of CBT skills training to all of the nurses in our home visiting teams, our reproductive child health teams, and even our school health program. So this all allows us the ability, I think, to be a little bit nimble and more responsive, as I say, to the needs of our community. What's coming next? So we have also been supporting observation for newly trained facilitators in Niagara. So we've been able to train another set of facilitators, as well as other interested public health units. And it seems we are part of facilitating, along with our colleagues at York Region, a bit of collaboration between a number of public health units across Ontario. It's exciting that there's a lot of interest. And so we brought this group together really to start to discuss what the implementation needs are across health units, what our capacity is to support scaling up, and sustainability of training and implementation kind of progress across various health units. Early days, and I anticipate we may have some additional interest following today's rounds, and hopefully some opportunities for some broader work across the province in this area. I think we have just a few minutes left before the Q&A period, so I am going to pass back to Ryan for some general summary slides, and then we'll head into a Q&A.
Thanks very much, Amanda. For handing it back over and for being such a wonderful collaborator. So as you all have seen from the slides and Amanda and Christina's sharing of what's happened since the studies have ended, the trials have ended, public health nurses can deliver effective online group cognitive behavioral therapy for postpartum depression to improve depression, anxiety, the mother-infant relationship, and even infant temperament. And the thing that we're most happy about, of course, is these changes are not only statistically significant, but also clinically meaningful. So when we look at how are the nurses doing compared to other people in the field, other deliverers, and we look at the research literature, and it looks like the magnitude of the improvements, the size of the effects for postpartum depression and anxiety are comparable to other treatments delivered by experts in studies. So whether it's one-on-one or people with a lot more training. So I think this is a real testament to how fantastic a job the public health nurses have done, that they're doing as well as more experienced therapists, and that their effects in group therapy are equally effective to those that happen in individual treatments as well. As we mentioned earlier, the treatment helps by 9 weeks. Christina Bradley will tell you by about 6 weeks is when you start to see changes, but these changes can continue up to at least 6 months after the group has ended. When we looked at the question of whether online versus in-person was better, it looks like they're similar. I think that there are advantages to delivering it in person. I think there are advantages to delivering it online. And it's just such a thrill to see Niagara trying to make it happen in both ways, really meeting clients where they are and trying to help them meet their needs in so many ways. Online delivery is, I live rurally. Online delivery is so fantastic for reducing a lot of those barriers that would keep people from coming to groups and things like that. So geographically dispersed areas, the online approach is obviously so helpful, as you all have come to know over the course of the COVID-19. And we think that online delivery could help with scaling as well. So we think, yeah, as I commented on, we think that delivery online has a lot of advantages, maybe increasing access. Recruitment was much faster during the pandemic in our online trial than in our in-person trial. There may have been more desire for support during that time, but we think that there is a desire for online treatments. And I think anyone who works with this population will acknowledge that there's still a bit, there can still be some reticence about coming to places where there are lots of people. Online treatment could reduce wait lists. We think this intervention can be scaled, and it benefits both mothers, birthing parents, and their families. Limitations of the randomized control trial that we ran is that we only ran it with one public health unit and in one region, so that there's some homogeneity in the sample and things like that. And sometimes effect sizes are smaller if you do across regions. The sample composition reflected Niagara's demographics, so it wasn't out of keeping with that, but the participants were more often white and married than might be the norm across the whole province. We didn't do any formal measures of fidelity to the intervention. That is, we didn't have people watch the sessions and then rate how closely the nurses delivered it to the ideal. That was for resource-related reasons during the pandemic, but it works. So fidelity is important in the long term, but in this trial, it was just fine, even though we think it was just fine, even though we didn't measure it. And then there was some loss to follow-up, but in the study, but this wasn't out of proportion with what we usually see in this population in research studies. So here's a fun slide that I convinced Amanda and Christina to let me put in. And this was from our in-person trial. And when it was the same as the online trial, except we could see people in person and we could assess the moms and their babies. And one of the things that we wanted to do was see if the intervention has an impact on offspring. And so one thing you can measure relatively reliably in pre-verbal infants is something called emotion regulation or emotion regulatory capacity. And emotion regulation is important because infants and young children who have poor emotion regulatory capacity as adults end up having 3 times the risk of developing significant mental health problems, dropping out of school, being unemployed, and even being incarcerated. So emotion regulatory capacity is a very important concept. And when the nurses treated the mothers and birthing parents, we tested the mums and the babies. And what we found is that in the babies, emotion regulation improved even over just the 9 weeks of the treatment. So something was happening with the moms that was causing them to interact with the babies in different ways and leading the infants to be able to regulate themselves better. The measure that we used is something called high frequency heart rate variability, which is a measure of parasympathetic nervous system function, our rest and digest system. And this system is responsible for regulating not only emotions, but also regulating physiological functioning. So what we noticed is that after treatment, the green group is the treatment group, that high frequency heart rate variability increased a significant amount, and it was actually a medium effect size, which is quite big in a treatment like this. So we don't know what this will mean in the long term, but it's a very promising early sign. We've done some other studies looking at emotion regulatory capacity over longer periods, and the 9-week, which this is a measure of, the 9-week time point is a good predictor of persisting improved changes. So we know that postpartum depression can have significant negative impacts on moms, birthing parents, infants, and families. And we know that typical treatment options are either not preferred, not easily accessed, or can be very expensive in the case of private treatment. We're so excited that public health nurses can effectively deliver both in-person and online group CBT for postpartum depression with benefits for participants, infants, and even public health nurses. I just want to we think that partnerships between research groups and public health units can be mutually benefiting. It's certainly benefited me, and we think highly impactful as well. So at this point in time, I'd like to hand it over back over to Sarah.
Thank you, Ryan, Amanda, and Christina for that incredibly interesting presentation. We'll now move to the Q&A pod to address some of the questions. Please continue to enter your questions into the pod if you have not already had the opportunity to do so. As moderator, I'm going to take the liberty and ask my own question first while we get more participation. You showed that the social support outcome was non-significant. Can you elaborate a bit on the mechanism of how this treatment intervention would improve that? And comment on if it was a different finding than the in-person delivery?
I'll jump in. So in the groups, what happens, Christina will attest to this, is that I think the nurses are fantastic, but the participants in the group are also magnificent at supporting one another, providing support, being empathic, and being there for each other. And what frequently happens in the group, somewhere about halfway through, is that someone in the group volunteers to sort of set up a WhatsApp group or some other thing. So we know that in the group they feel the experience of social support, but often they then organically decide to link up afterwards, and they sometimes do that. So that's the mechanism. In terms of neither the in-person nor the online delivery was associated with a statistically significant improvement in social support. We're not sure if that's the measure or it just doesn't happen after the group and things like that. So that helps.
Okay, thank you. Okay, our first question is, how did you get the buy-in from management to deliver this program?
Good question. It's probably one for me. You know, I will preface by saying again that Niagara's journey has been several years in the making. So I think we have had wins and support growing over that time. So it starts as a research partnership that's very mutually benefiting, and we saw it as a win-win. You know, we were able to skill up public health nurses and be part of testing and intervention that we weren't sure about, but we knew there was a need. In general, I would say what has supported buy-in in Niagara has been that demonstration of need and demonstration of a gap in the community. So our ability really then to address barriers, address equity, and then really some evidence that links supporting postpartum depression and anxiety to other public health priorities. So really, you know, spending a bit of time understanding your community, what the needs are, what the gaps might be, and unpacking a bit of the evidence that makes sense in terms of each local health unit's own priorities.
Thank you. Our next question is, can you provide examples of CBT training that PHNs can complete online?
I'm not sure that I have an answer for that one. I'm not sure, Ryan or Christina, if you're aware of any more. I know Christina has, you know, done a bit of work in that area personally, so maybe she's best to speak to it.
Yeah, I think there's a variety of universities and that might offer that as a, you know, professional development opportunity. It would be a matter of taking a look and exploring the different, you know, post-secondary options and certifications, or, you know, master's degrees in social work or psychotherapy.
Great, thank you. Was the attrition rate lower with the virtual group? And I'm guessing this is compared to in-person.
I mean, I think in the study, attrition was a little lower in the online intervention. Christina was alluding to that. I mean, I made a joke in my clinic, like when people started no-showing to appointments, that's when we knew the pandemic was easing, because as Christina alluded to, people just didn't miss appointments during that time. So in the study, there were questionnaires and things, so those things might have contributed to some dropout as well in the study versus but the dropout rate was a little bit lower in the online one, but not staggeringly.
Thank you. Our next question is, I'd be curious to know about, I'd be curious to know how these scores compared to non-PHN-led CBT groups for similar populations, i.e. when led by mental health practitioners or by community agencies.
Yeah, there are actually a surprisingly small number of sort of randomized control trials that allow these kinds of comparisons, and the effect sizes that we saw in the nurse delivered interventions were sort of medium effect size 0.6, 0.7, and the biggest meta-analysis done of trials delivered by others, the effect size was 0.63. So it's sort of right there with them.
Thank you. Okay, so our next question is a great one, and I think something that we've talked about before. The concept of group CBT, in person or online, by RNs is a great one, but I'm uncertain about the role of public health in this versus the treatment system. In particular, Dr. Van Lieshout, have you discussed this work with Ontario Mental Health and Addiction Center of Excellence and or individual Ontario health teams for potential for them to invest in it?
No, haven't talked with anyone else about it. Have had a good thing going with public health in Niagara, and I think it was we had only had one trial until now, so I think it might have been a bit premature to start to talk about scaling and things like that. But now we've got two very solid results, and it's looking good. And I'm glad Amanda raised her hand, because I'm not going to get into the debate about this being public health versus something else, because that's swinging above my weight there.
I'll chime in briefly, really to say that I think in our experience anyways, the treatment system has gaps, specifically in terms of evidence-based models of care for those experiencing prenatal and postpartum depression, anxiety symptoms. And, arguably an intervention addressing those symptoms in this population is about as upstream as it gets in terms of promoting early child development, promoting secure infant attachment, and developing supporting really mothers and birthing parents with emotional availability to respond to the cues of their infants and young children. So I think that's where you can really make that case in terms of prevention and upstream work and addressing other public health priorities that emerge further downstream.
Thank you. Our next question is, during the sessions, did the PHNs need to utilize other skills that scoped beyond CBT content, i.e. breastfeeding support and other things? Christina.
Yeah, so we're really focused on the curriculum and addressing the cognitive behavioral model within our session. So that is our primary focus. Sometimes what comes out of that are really strong emotions and thoughts about parenting, breastfeeding. So typically a lot of those conversations, we might offer that, if appropriate, afterwards. We might remind them oh, by the way, I'm a lactation consultant. If you want to message me for additional support after, I'm happy to do that with you. Or sometimes we have parts of the activities open up for brainstorming opportunities. So we might highlight, when appropriate, some of our local programming or provincial programming or community supports that are available. But typically we don't deviate from the curriculum in order to address specific lactation or parenting issues during that time, because the focus is on emotions, thoughts, behavioral activation.
Great, thank you. So our next comment and question is, in my experience with patient groups in psychiatry practice, there are some real benefits of out-of-group social connections that develop in person or WhatsApp, as you mentioned, Ryan, but also some very real risks of harm. When brought to scale, this will certainly be an issue to overcome. Have legal and risk folks reviewed this? Has this come up?
Well, I'll let Amanda might be better positioned to answer some of this. We don't tell people to connect. It's not, if they want to, we don't stand in the way. I'm not sure if that makes a difference, but I think certainly it's not a prescribed part of it. And so if they choose to, I mean, we, I suppose, provided the place where they could link up and speak with one another, but we don't tell them to do that. Amanda or Christine?
I would echo that. I think that might occur outside of like the role and scope that we are, involved in. And I'm not aware of any issues that have arisen in the groups we've facilitated.
Yeah, typically I would agree it's client driven. So for example, a client will say, does anybody want to meet up at a park, or is anybody interested in connecting over Facebook, typically towards the end of the series. So it's always client driven with the option of everybody to opt in or opt out of those connections.
It is a good question, I suppose. If we were to get support to scale it from anyone other than like Amanda and us, then I think it's something to certainly like put on the agenda. So thanks for asking it.
Yeah, great question. So the next question is, are there any plans to look at implementing CBT one-on-one, so individually rather than a group setting?
I mean, I think I can comment a bit here in terms of some of the additional training that we have, kind of co-developed and implemented with our home visiting staff, our other staff in reproductive child health and school health. I would say that, it isn't that they're delivering CBT one-on-one with their clients in home visiting settings, but have been skilled up with some CBT-based approaches that they are welcome to use with their clients one-on-one. And so it wouldn't be in place of, I think, some psychotherapy, if that would be of benefit to them and it is accessible, but gives the nurses some tools that they can use one-on-one that are based in CBT principles. I don't know if you want to add anything, Ryan, about that particular training, but that's really, where we're at now anyways, in terms of one-on-one interactions.
Yeah, so a lot of people will talk about preferring one-on-one, like the clients will say that, but once they get into the groups, they seem to really see the benefit of it. But it's always scary, when you go into a group with a bunch of people that you haven't met before. So, but usually the individuals in the group are so fantastic, including public health nurses, that they usually happen.
Great, thank you. Okay, the next question I'm going to ask is also one that I had. So what did the usual care control group include? I did notice on the first EPDS score outcome that the control group had also had a improvement in scores. And is that part of the natural progression of PPD, or what did they get as well?
Yeah, so usual care, we didn't impose any restrictions at all on anybody. If they wanted to see their family doctor, they could do that. If they wanted to see a psychiatrist, they could do that. If they wanted to see their private therapist, they could do that. So there were no restrictions placed on it whatsoever. So the improvements could have been, well, I'm in this study now, I'm not getting treatment from the public health unit, so maybe I'll go and do something else. Also, as the study went on, the pandemic was coming to a close, so we think that there's probably a natural, and then there's the natural history of postpartum depression is that it can resolve in a proportion of individuals.
Excellent. Okay, we have time for a few more. Was there any pushback from community partners who deliver mental health services? Was there concern from these partners on PHNs delivering these services?
Yeah, I haven't experienced pushback from community partners, and I would say we worked closely with our mental health program in Niagara to understand what they were able to offer and support in terms of our clients who might be experiencing postpartum depression or anxiety. They really have limited supports. I think we heard that theme from a number of partners in the mental health realm, and so had welcomed that we were offering this intervention. I think we have referrals that go both ways between our programs. So we haven't experienced that pushback. We have had interest from other community partners as well to understand. So Strive Niagara being one example where how can we bring this really to similar groups that might be already convening in the community or working with our community partners. So I would say, you know, in my experience, we have high buy-in from our community partners. I don't know, Christina, if there's anything else that you've experienced or would want to share.
No, I don't think we've had similar. I don't think there has been any pushback. We do receive referrals from these agencies from a variety of different agencies referring their clients to the program. Generally, I think it's very supportive.
That is actually a great lead into the next and last question, which is, how did you promote the CBT group in the Niagara region?
Yeah, great question. We are still sorting out promotion, right? Trying things. So we have tried some of our traditional means, have been social media ads, sponsored, as well as like social media posts and content. That seemed to be really effective during the study phase as well. And so that is ongoing, like several times a year, we'll put a little push out through our social media channels. We've also been able to promote to our primary care community through a few different means. So our physician newsletter, we have some direct contact with our hospital partners, like through other meetings that we are engaged in, and communication with our midwife partners and some specialties there. So we are actively promoting to those groups. We find a large number of our referrals or registrations really come through other public health programs. So we also make sure that our colleagues in Healthy Babies, Healthy Children and Nurse Family Partnership kind of know what's happening, promoting the next group through them. They often have interaction with the clients that we're looking to serve. And so that's a large referral source, as well as our Niagara Parents. So our Niagara Parents is our like central phone line, live chat, email, a number of modes to reach a public health nurse. And sometimes a call about infant feeding or sleep might turn into a call about mental health, might lead to a referral to CBT. So some of that just sort of happens in-house, and make sure our teams are aware of what's next for the program so they can promote it as well.
Thank you so much for that great discussion. So as we wrap up today's PHO round session, I would like to thank Dr. Ryan Van Lieshout, Amanda Hicks, and Christina Bradley for presenting. Wonderful work. I would also like to thank everyone who joined us for today's session. You can expect to receive the brief and anonymous PHO round survey for today's presentation. Please try to complete this to help us improve our programming. Lastly, to access past PHO rounds presentations and view confirmed upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Thank you and have a wonderful day.